Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the CRASH course are listed here. So let's start our case. So in this case, we have an 8-month-old male who presents to the emergency department with a history of lethargy. He was seen 3 days ago with fever and URI symptoms. He was sent home at that time with a diagnosis of a viral illness and recommended supportive care. This morning, he had become more irritable and was less active than usual. He has vomited 3 times and his urine output is noticeably decreased. He has no diarrhea. Birth history, he was full term, normal delivery, weighed 3.1 kilos at birth, and there were no complications. There is no past medical history. His immunizations are up to date and he received his 6-month shots last month. Feeding history, he takes Similac with iron and baby foods. Socially, he lives with his mother, her boyfriend, a 4-year-old brother, and a 7-year-old sister, and they just moved from Miami last month. Family history includes a maternal grandmother with hypertension and a maternal grandfather with a myocardial infarction. On physical exam, he has a temperature of 40 degrees Celsius, pulse is 90, respiratory rate is 30 but is irregular. His blood pressure is 120/90. His weight is 10 kilograms. He is lethargic and arousable only to painful stimuli. His anterior fontanelle is full and tense, and he has questionable neck rigidity. His tympanic membranes are red and bulging. His pupils are reactive, but his eyes do not focus well on his parents. His heart, lungs, and abdomen are normal. His color and perfusion are good. He has no petechiae. He moves all his extremities weakly, and his deep tendon reflexes are hyperactive. So in this case, we have an 8-month-old infant coming in with fever and lethargy. We also noticed a full fontanelle on exam, and also some possible neck stiffness. So the main thing on our differential diagnosis at this point is going to be meningitis. So this case is going to focus on meningitis and what to look for and how to interpret CSF findings in a pediatric patient with possible meningitis. So if we're thinking about possible meningitis in an 8-month-old, let's talk about how to approach this child. So possible meningitis as our major diagnostic consideration. When you're thinking about meningitis in children, there's a few buzzwords that you have to keep in mind as you approach that child. There's particularly 3 buzzwords that, if you use, equal meningitis, right? Those 3 buzzwords are lethargy, which is already up as part of this case. If you use the word lethargy to describe the child in your assessment, that child, you have to do a spinal tap on, because lethargy equals meningitis. Right? Parents might give you the history of being lethargic, right? But you have to make your own assessment. If your neurologic assessment of the child is that they are truly lethargic, right? Then you have to do the spinal tap, okay? If you're not going to do the spinal tap, do not use the word lethargic. Do not say they have lethargy, okay? Because if you use that word as part of your assessment, then you have to say that then you have to do the spinal tap. Okay. The other couple words after lethargy is, one word is irritable. If a child is truly irritable, you must do the spinal tap on that child. Okay. Parents might again give you the history that they're kind of fussy or irritable, right? But you have to assess them. So in your assessment of the child, if the child is truly irritable, then you have to do a spinal tap, because irritable means meningitis. If you're not planning to do the spinal tap, do not use the word irritable in your assessment of the child. And the last word is inconsolable. The word inconsolable equals meningitis in pediatrics. So again, parents might say my child is kind of fussy or inconsolable. That's fine, but you have to make your own interpretation. If your assessment, your neurologic assessment, or your general assessment of a child is that they truly are inconsolable, that means meningitis and you have to do the spinal tap. If you're not planning to do the spinal tap, then do not use the word inconsolable. Okay? These three words equal meningitis in pediatrics: lethargy, irritable, and inconsolable. Okay? If you use any of these words as part of your assessment of child, you have to do the spinal tap. If you're not planning to do the tap, or you don't think the child has meningitis, then do not use these words. Okay? Or if you're going to use these words, make sure that you qualify them, right? Then you need to qualify it. Irritable but consolable, right? Lethargic but arousable. Okay? So if that's what the child is, right? If they're not really lethargic, but they're kind of a little bit sleepy, but they're arousable, right? Then you say they are lethargic but arousable, okay? Then you don't necessarily have to do the spinal tap. Or they are irritable but consolable. So if you say they are irritable but consolable, again, that means that they might not have meningitis and you don't have to do the spinal tap, right? So if you're going to use any of these words, make sure you qualify them. Lethargic but arousable, irritable but consolable, okay? If they truly are lethargic, truly are irritable, truly are inconsolable, then you have to do the spinal tap. But if you don't think they are, you can quiet them down, you can console them, they're sleepy but they're arousable, then you document it this way, and then you don't necessarily have to do the spinal tap, but it is still a clinical judgment to help you decide whether you need to do the spinal tap or not. So that's one of the points about meningitis that is important, is the choice of words that you use, and recognizing that parents might use some of these words to describe the history of their child, but you need to do your own assessment, your own general assessment, your own neurologic assessment of the child to decide if they truly are irritable, lethargic, or inconsolable, and then you have to do the spinal tap. But if they really aren't that, then you have to qualify it if you're not planning to do the spinal tap because you don't think the child actually has meningitis. So you need to keep this in mind as you're approaching a child with possible meningitis. So the first question is, what is the most likely cause of meningitis in kids? What is the most likely organism causing meningitis in pediatric patients? It's not pneumococcus. It's not E. coli. It's not group B strep. The most common cause of meningitis in kids is viral. I didn't say what's the most common bacterial cause of meningitis in kids. I just asked what is the most common cause and the most likely organism causing meningitis in kids. And the most likely cause is going to be viral. So what's the most likely virus causing meningitis in pediatric patients? The most likely virus is enterovirus. Enterovirus is the most common cause of meningitis in all ages, in adults and in pediatric patients. So the most likely cause is viral meningitis from enterovirus. But you can't differentiate that clinically, so you have to think about the bacterial causes in pediatric patients as well. And when I think about bacterial meningitis in kids, I break it up into age groups. So we can talk about the newborn age group from 0 to 2 months of age. We can talk about the toddler group from 2 months to about 5 years. And then we can talk about kids who are greater than 5 years of age. And there's different bacterial causes of meningitis in each of these age groups. In the newborn period from about 0 to 2 months of age, what are the most likely bacterial causes of meningitis in this age group? Number one most likely cause is going to be group B, beta hemolytic strep. Number two is going to be E. coli. And these two organisms by far are the most common causes of bacterial meningitis in the newborn period. Group B strep, number one, E. coli, number two. And then far below this, still a consideration, not as common, but still something that needs to be considered, includes Listeria and occasionally even Enterococcus. So when I think about meningitis in the newborn period, these are the organisms that I really consider. So if these are the bacteria that you are worried about, what is the empiric antibiotic coverage that you are going to choose to cover the newborn period based on this list of organisms? So in this age group, we typically do not just use one antibiotic. Many times we will use 2 antibiotics to cover this group of bacteria. So the common organisms that are causing bacteria are here for the newborn. So the antibiotics that we empirically will use, one is going to be ampicillin. And ampicillin has to be one of the antibiotics that you're going to use. Of these organisms, ampicillin is the treatment of choice for which 2 of these organisms? Ampicillin is the treatment of choice for Listeria and Enterococcus. So you have to use ampicillin in this age group to cover Listeria and Enterococcus. Ampicillin many times will also cover your group B strep, but it's not necessarily the treatment of choice. There's other other antibiotics that you can use to treat group B strep. But ampicillin is the treatment of choice for Listeria, Enterococcus, and in this situation will also cover your group B strep. But it will not cover your E. coli. So then in this age group, many times we'll use ampicillin and gentamicin. The gentamicin as aminoglycoside will cover the gram-negative rod of E. coli. So in this age, many times in the newborn period, we'll use ampicillin and gentamicin. Sometimes you can use a different combination. You have to use ampicillin to cover your Listeria and Enterococcus. But if they're maybe older than 2 weeks of age, you might be able to use a different antibiotic other than gentamicin. And then instead of gent, we'll use a 3rd generation cephalosporin in addition to the ampicillin. So what is the 3rd generation cephalosporin that we'll use in this age group to cover these organisms? You might think it's ceftriaxone. Actually, ceftriaxone we don't want to use in the newborn period because it causes biliary sludging and also disassociation of protein from bilirubin, which can lead to kernicterus. So it's a relative contraindication to use ceftriaxone in the newborn period, especially under 1 month of age. So there's a different 3rd generation cephalosporin that we will use that doesn't have as much effect on the liver and the biliary tract, but still has similar coverage as ceftriaxone and gets into the CSF almost just as good as ceftriaxone. And that 3rd generation cephalosporin is cefotaxime. So a lot of times we will use the combination of ampicillin and cefotaxime in the newborn period. Typically under 2 weeks of age, we'll use ampicillin, gentamicin in the newborn nursery, in the NICU. We tend to use a lot of gent, but if they've gone home and they're coming back with a fever, rule out sepsis, rule out meningitis, or they're older than maybe 2 weeks of age, sometimes we'll use ampicillin and cefotaxime combination instead of the ampicillin and gentamicin. Okay, so now let's move on to the toddler range and think about the bacterial causes of meningitis in this age group. So the number 1 cause in this age group is going to be pneumococcus, and that's number 1. Number 2 is going to be meningococcus, and number 3, which is much less common now, is H. influenza type B. H. influenza type B used to be the number 1 cause of bacterial meningitis in this age group, but because we developed the conjugated vaccine, since then it has dropped down to number 3. Now, pneumococcus also has a conjugated vaccine, the Prevnar 13, which covers the 13 most common serotypes of pneumococcal strains that cause invasive disease, including meningitis, but we are still seeing pneumococcal invasive disease with serotypes that are not covered in the Prevnar 13. Hib vaccine was very effective because there's only 1 serotype of Hib, so that vaccine is very effective for that 1 serotype. Pneumococcus has up to 90 serotypes, so that's why we still see invasive disease. And the same thing with meningococcus, we have the meningococcal conjugated vaccines, but again, there's other serotypes that are not covered in the various vaccines, so we still see meningococcal invasive disease. Okay, and then in the older than 5 years of age, what is the most common cause of bacterial meningitis in this age group? In this age group, now meningococcus becomes the most common cause, bacterial cause. And then number 2 now becomes pneumococcus. And then number 3 is still H. influenza type B. So it's the same organisms, but meningococcus is more common, and you don't see as much pneumococcus once you get to 5 years of age. Now, what is the empiric antibiotic of choice that you're going to use in both of these age groups, since it is the same organisms you're worried about. So in this age group, you're going to use empirically IV ceftriaxone, right? So this is where you're going to use your ceftriaxone in this age group to cover both of these type of organisms in this age group. Now, in addition to ceftriaxone, you might consider giving other antibiotics that will cover possible resistance to ceftriaxone. So a lot of times when a child comes in and is very sick, there's plus or minus the use of vancomycin to make sure you're covering for any pneumococcal resistant strains that are not sensitive to ceftriaxone, or if a child is just coming in very sick, you're just going to hit them hard with antibiotics and strong antibiotics. So that's why a lot of times they do ceftriaxone, but also add the IV vancomycin as well to get that broad coverage to cover for everything. So these are the various organisms that you're going to worry about based on the age group, the organisms to worry about, and then the antibiotics that you're going to empirically use to cover for these type of organisms. So that's the first part that I wanted to cover in this case regarding this 8-month-old child with possible meningitis, to make sure we understand the organisms, first of all, for this child in this age group, but also the other age groups that you might be dealing with, and what are the organisms, and then what is the empiric antibiotic of choice that you're going to use at that point. And now then we've established that, now we can move on to some of the clinical presentation of meningitis and try to understand how kids of different ages might present clinically with meningitis. So children of different ages will present differently based on their clinical symptoms with potential meningitis. So in older kids older than 5, those kids will present with the typical findings of meningitis that you see in adults and you see in adolescents. So what are some of those findings that you might see an older child presenting with meningitis? Those are the common ones, right? They include fever, lethargy, nuchal rigidity, neck stiffness, photophobia. They might be vomiting, right? They might have particular rash, right? They would have a positive Koenig's and Brzezinski sign on physical exam. So those will be the common ways that an adult or a older child will present clinically with meningitis with those signs and symptoms. The newborns, however, are a little bit different, and I think we need to understand how a newborn with possible meningitis might present, because they don't typically present with the clinical features of an older child, an adolescent, or an adult with meningitis. So newborns can present a little bit differently. So the first point I want to make about newborns presenting with meningitis is related to fever. So a newborn with meningitis might have a fever, and they can present with that fever. Or they can actually have the opposite, and they can actually have hypothermia. So a newborn that has an overwhelming infection of sepsis or meningitis, they might not be able to mount the normal response that you would typically see where they mount a high fever from that infection. So they might actually have such an overwhelming infection that they're not able to mount a fever, and they are actually hypothermic. Or they might have temperature instability, so they can't maintain their body temperature. So hypothermia, in my mind, is actually a more ominous sign than a fever, because the hypothermia tells me that that newborn, that young infant, is not able to mount a fever, not able to mount the normal response that they should have, and they have such an overwhelming infection with the sepsis or meningitis that they are now hypothermic. So that's one thing to consider that is many times different than adults and older children, is that kids might not have a high fever with meningitis. They can have a normal temperature, or they can actually be hypothermic. So I think that's something to consider. The other thing to think about in the newborn period is if they have meningitis, they will have decreased activity, right? But how do you assess decreased activity in a newborn who sleeps 20 hours a day, right? They're always kind of lethargic. They're always kind of sleeping. So how do you assess the activity level and it being decreased in the newborn period? So what activities do newborns do? They basically do two things, right? They feed and they have bowel movements. So if a child has decreased activity in the newborn period because they might have meningitis, they'll exhibit that by issues related to feeding. They will not wake up to feed. They will not be interested in feeding. They might be vomiting. They might have abdominal distension. They might not have a good sucking reflex. So all of these are related to feeding issues, and they might have some sort of feeding intolerance. So anything related to feeding issues and poor feeding and feeding intolerance can be a sign of meningitis in the newborn period. So I think that's another point to consider, and how that might be different from adults and older children. Now, in newborn babies, sometimes it's very hard to assess for neck stiffness, right? Because they're so tiny and they have a small neck, so they might just be kind of stiff in general. Like you try to pick them up and they're just kind of stiff in general, and you're not really able to assess their actual neck stiffness or nuchal rigidity. So sometimes it can be hard to assess that. So that's something to consider. Okay. They also might have a bulging fontanelle, right? Like our child in this vignette had a bulging fontanelle. So if they have an open fontanelle, they have increased intracranial pressure from the meningitis, and they might actually have a bulging fontanelle. And that's actually important for newborns because newborns, because they have an open fontanelle and they have a, if you will, a pop-off valve to equilibrate the pressure in their CSF, a lot of times then they will not herniate when you do the LP. In older kids or in adults, you always worry about doing a spinal tap if they have like a brain tumor and an increased intracranial pressure, that are they at risk for herniating. So children who have an open fontanelle actually are at less risk for herniating because they have this pop-off valve, if you will, that then can kind of distribute the pressure intracranially and put them at less risk for herniating. So that's one thing to remember about that as well. The other point I want to make is related to breathing and the respiratory rate of a newborn infant that might have meningitis. So what would you expect the breathing to be doing in a newborn who has possible meningitis? Typically, when you look at the breathing, they typically are going to be tachypnic. They're going to have an increased respiratory rate. And why is that? Why do they have an increased respiratory rate when they are septic or having possible meningitis? They could be tachypnic because they have a fever. That can add to the tachypnea, right? But many times, the reason they're tachypnic physiologically is that they actually have an underlying acidosis. They have an underlying metabolic acidosis from the sepsis and the meningitis and the infection. So then they have a compensatory respiratory alkalosis in which they are tachypnic to blow off excess CO2. So that's why they are tachypnic. Now, newborns with meningitis, sometimes they might not be tachypnic. Just like with a fever, you can have the opposite of tachypnea as well. Where fever, you were hypothermic, so with respiratory rate, you could be tachypnic, which is the normal response that you want to get, but they could be the opposite of that, right? They can have slow respirations, shallow respirations, or actually go all the way to apnea as well. So that they can present in different ways as well. And the apnea could be related to the fact that they're so kind of floppy and hypotonic that they can't exert enough pressure to take good breaths. So they could be floppy and hypotonic as well. And that can add to the apnea. Or they can have central apnea because they have an affection of the brain, so that they have central apnea as well then. And then the other thing related to respiratory rate and breathing is another important finding in newborns that you have to really think about. What might you hear in a newborn if they have meningitis when you listen to their breathing? What might you notice about their breathing? You might notice they might have retractions, and they could have that. You might notice they are maybe even wheezing, depending on if they have other URI symptoms. So they might have that, right? But what other one feature when you listen to them that you might hear related to their breathing if they are septic and if they have possible meningitis? They will be grunting. A newborn with meningitis, you might hear them grunting as they take their breaths, right? So grunting is at the end of expiration, they close their glottis, right? They close their airway and make a grunting sound at the end of expiration. Right? So as they take their breaths and they have expiration, they close their glottis to make the grunting sound. And what they're doing is they're actually generating auto PEEP, auto positive and expiratory pressure. So they are trying to generate auto PEEP to try to pop open those alveoli that are actually being filled with fluid as they go into pulmonary edema and ARDS. So a baby that is grunting should really, really worry you, because they could have meningitis, they could have pulmonary edema, they could have ARDS. So if you ever hear a grunting baby, you have to be really worried about that baby. It could be sepsis, it could be meningitis, or they could have something primarily going on in their lungs. They could have bronchiolitis, they could have asthma, they could have pneumonia, they could have a pneumothorax, they could have any of those things. But also the grunting could be more of a sign of a systemic type of process, and not just primary lung pathology, but a systemic process like sepsis, meningitis, peritonitis, something that's causing them to go into ARDS, and now they're grunting to generate that auto PEEP to open up those alveoli that are being filled with fluid as this process develops then. So I think those are the common findings you have to think about, especially in the newborn period that we just mentioned, that can be able to compare and contrast that with older kids and how they might present with meningitis. So that kind of reviews how a child with meningitis and different ages might present clinically. And now we're going to move on and start to look at how to interpret CSF findings to help us decide if a child might have meningitis and how to interpret those results.